I've been invited to talk about overuse injuries and return to play. But if we look in the program, there's also a lot of other talks talking about different specific types of overuse injuries. And so my job, is to talk on a more broad level, on a theoretical level, about overuse injuries and return to play. And we've been asked to start with a slide like this. How will this talk affect your practice? And I would love to come with some groundbreaking new research that's going to change your practice from tomorrow. But unfortunately, that's not going to happen. But my plan, my hope, is that by going through in a theoretical way and looking at various models, we can recognize the specific challenges and the specific opportunities that overuse injuries present us. When is removal from play necessary? How might an understanding of the real causes of overuse injury affect our return to play success? And how can we engage coaches in the return to play process? So I'll start just by defining what it is exactly we're talking about when we say overuse injury. Then, I know we've been focusing on it now for 2 days, but just a quick kind of thought. Why is this decision so important? Why should we be here to have this conference? And then the real meat of the lecture, what's the actual difference between overuse injuries and acute injuries? And of course, some take-home messages, but what I'll try and do, instead of doing it just one slide at the end, I'll do it at a couple of points throughout the talk. So what is an overuse injury? Isn't this a fantastic picture? What is it exactly, an overuse injury? And if you go into any sports medicine, sports injury textbook, we'll go through the various tissue structures, tissues in the body, and there'll be a range of different injuries classified as overuse or acute. But on a more theoretical level, we're talking about injuries caused by a cumulative transfer of energy compared to those caused by an instantaneous energy transfer. So a gradual process of cumulative micro-trauma versus an instantaneous process of macro-trauma. That the tissue prior to this event is assumed to be completely healthy. And there are normally quite easy to classify an injury as one or the other, but there are some grey zones where injuries that perhaps come on very quickly and the athlete might experience it as an acute injury is in fact an overuse injury if the energy transfer that caused that symptomatic increase isn't plausible to cause a damage to a previously healthy structure. But for our purposes today, we're really focusing on these cumulative trauma events, okay? Things that are caused by accumulation of load, accumulation of micro-trauma. Now, why is our return to play decision so important? Well, in the short term, we're talking about minimizing the risk of injury recurrence. So we talk about injury prevention, and we work with this a lot up in Oslo. And the main goal, the main dream, is primary prevention, so stopping the injury from occurring ever. And then we also talk about secondary prevention, which is early identification of an injury so that we can get in, act early, and minimize the consequences. But tertiary prevention is when we're trying to prevent second injuries after the first injury has healed. And that's really the return to play aspect. And then we have the long-term consequences, or the long-term importance, of a good return to play decision. So what are the long-term health consequences of allowing the athlete to return to play? Now, for some injury types, for ACL injuries, for example, we know that there is an increased risk of osteoarthritis. And those athletes returning to high-level pivoting sports have an even higher risk of osteoarthritis. What do we know about overuse injuries? Well, very little. So we don't have any research that shows what happens over longer periods for athletes with overuse injuries. Are these overhead athletes with SLAP lesions at greater risk of shoulder problems when they're older? Are cyclists with patellofemoral pain at greater risk of having patellofemoral osteoarthritis? These questions we can't answer, and we need long-term prospective cohort studies to be able to look into these questions. But the short-term goals we do know quite a lot about. So we know that there is a large propensity for overuse injuries to recur. We have a lot of these big epidemiology studies going on up in Oslo, and a vast majority of the injuries that we record are recurrent injuries. So very, very few first-time injuries in elite athletes. upwards of 90% of the injuries, the overuse injuries we record, are not first-time injuries. So we have a huge need to reduce the rate of re-injury. Okay, so what is it that's different about overuse injuries? Well, we'll start with a theoretical model of acute injury. So here we have a injury event, a clearly identifiable energy transfer causing damage to a tissue. And theoretically, the amount of damage and the consequences, the symptoms, are worst at the point of injury, and there is a relatively linear improvement over time to the point where the athlete can return to sport. Now, we all know Adam Meekins' graph, which looks something like this, and that's a very good reflection of reality, but it's not so relevant here, because what we're thinking is it's just a linear process from worst and getting better over time. Overuse injuries, in contrast, they start gradually, and the consequences and the symptoms and the structural damage fluctuates over time. And that's caused not by one single energy transfer, but repeated episodes of overload. And in this example, we see perhaps there's been some kind of good intervention put in around this point, so there's a gradual improvement over time. But in reality, we see many overuse injuries that just continue, and it becomes a normal part of that athlete's athletic career, that for the rest of their career, they're dealing with these symptoms and consequences of overuse problems. Now let's think about it in a bit more detail. So the process of injury actually starts before the athlete notices any symptoms, but at some point it will cross the threshold for pain and they'll become aware of the problem. So we all know athletes, they don't stop then, they don't just pull out of sport as soon as they notice a bit of pain. They continue, but perhaps with modified participation. And that could be by reducing some of the training parameters, so the frequency or the intensity or the type of training, or they could try and mask symptoms with analgesia or anesthetics or manual therapies, but they really try and continue to play, continue to participate. And we know from our studies up in Norway that around about 90% of overuse injuries don't cross the threshold for time loss. So what's the relevance here for return to play? Well, instead of focusing necessarily on return to play, perhaps our first question should actually be removal from play. And Christian spoke about this earlier today, and it's a really, really good point. So we have also this great framework that Ian presented, the START framework for return to play decision making. But exactly the same framework is relevant for the removal from play decision. Okay, so we have the assessment of the health risk, assessment of the sporting risk, and these risk tolerance modifiers. So we can all imagine the example of an athlete with an overuse injury coming into the Olympic Games and all the pressures that are involved there. And our decision to allow them to continue to compete is hugely influenced by that. But as sports physiotherapists, which I guess most of us here are, the two biggest questions, I think, are: can we successfully treat the injury whilst allowing some form of modified or continued participation? And what are the actual risks of allowing that? So if we mismanage the load, what can go wrong? Now, this first question has been addressed by a couple of research studies. Firstly, by one of my colleagues up in Norway that had a group of high-level volleyball players, and they were randomized into a group that did a kind of modified Alfredson protocol for the knee, where they were doing daily eccentric training, and the other group received no treatment. And all players were allowed to continue to play volleyball for the season. And in these two groups, there was no difference. So that the intervention, which had been shown to work in volleyball players previously, but in those that had been pulled out of sport, didn't work in this case. Then there was a great study from Sweden by Karin Silbernagel and her colleagues, and she's coming up later, so I hope I don't steal too much of her thunder here. But they had a great project where they took running and jumping athletes and randomized them into one group that had a graduated exercise program, so a graduated loading program, but they were pulled out of their sports participation for the first 6 weeks. And the second group with the identical program, but they were allowed to continue, but using a pain monitoring model to self-regulate their own loading. So what they were told was that they could continue to participate as long as it was under 5 in the numerical pain rating scale. And different to the Norwegian study, this Swedish study found that both groups improved, and the improvement was similar in both groups, so it wasn't necessary to pull the athletes completely out of participation. This is very encouraging, but what's the difference between these two papers? So the first is this allowance of self-loading or self-monitoring of their load. So the athletes were self-regulating and reducing their load so that they weren't going over 5 in the pain. And the second potential explanation could be that in the Norwegian study, it was exclusively volleyball players, and that's a very, very high loading sport on the tendon, and perhaps that in some sports it's more necessary to pull athletes out of play, whereas in other lower loading sports we can allow some kind of modified participation. And if we do that, so if we allow modified participation, what can go wrong? What are the risks? And I guess many of us hopefully are aware of this fantastic model of the continuum of tendon pathology that's been proposed by Jill Cook and Craig Purdom. And it's a 3-step, they describe a 3-step process in tendinopathy, ranging from a reactive tendinopathy, a disrepair phase, and a degenerative phase. So this is indicating the degree of chronicity and the degree of structural damage occurring within the tendon. And what's interesting when you look at this model is that, in fact, there's no final step of tendon rupture, whereas theoretically there probably should be, right? That it's starting from a healthy tendon and getting more and more and more degenerative. To a certain point, it should break. But it's my understanding that it's not in the model because clinically we see it so rarely. So the patients that present with tendon ruptures often don't have symptoms prior to the rupture that would indicate this degenerative process going on. But that's a really theoretical point open to debate, and it may also be different for elite high-level athletes. But either way, I think when we're thinking about what can go wrong in these early phases of tendinopathy, and if we mismanage the load and we allow an athlete to continue to participate, then we're risking increased structural damage and an increased risk of chronicity. For bone, the final phase is included in the model, so complete fracture. And this is a model that's been adapted by Stu Warden in his great work on stress fractures. And that's there because clinically, unfortunately, we do see from time to time that stress fractures progress to complete fractures. So here we have a lovely example from the Olympic Games, which is shocking. And look, I can't comment specifically on this athlete's case, but you can imagine the situation where an athlete is in the Olympic Games, they have signs of a stress fracture or even evidence of a stress fracture, but because of all these pressures on the athlete and on the therapist and the medical team, they decide that they want to go for it. Okay, let's use some masking medications and have a go. But you can see if that was the case here, it didn't go so well. Okay, so the first take-home message slide then, if we're talking about removal from play, is that we do risk, in tendinopathy, we risk increasing the structural damage, we risk increasing the chronicity of the problem if we mismanage the load, but that if there is a good load management, perhaps using this pain monitoring system, then we may still have a good clinical result with allowing modified participation. But maybe in these really high tendon loading sports, it will be necessary to pull the athlete out for a short period. Whereas in stress fractures or stress injuries, I think the case is a bit clearer. We do really risk fractures, and I think as standard practice, we need to remove the athlete from play. Okay, what else is different about overuse injuries? And now I want to focus on the causes. So we have this model of injury causation that was described now over 20 years ago by Winner Movis. And this is one of these fantastic models that should be on the wall in your clinic because it really helps you to explain to patients the interactions between these intrinsic risk factors within the athlete, extrinsic risk factors, and the inciting event. But if we look at this model, it's quite obvious that it was described or originally designed with acute traumatic injuries in mind because this inciting event is a single event, so a high energy transfer event, clearly identifiable, which can be described so that what was happening, the situation in the game or the interaction between players, and that can be described either clinically or with advanced biomechanical techniques. But for overuse injuries, the inciting event is actually a mismanagement of the load. Okay, it's one of these parameters of loading, like the frequency or the intensity or the timing, Or it could be that the actual loading program doesn't change, but the athlete's ability to recover between sessions might be impaired. So perhaps they're sleeping badly, they're stressed out, something like this, but for some reason, they are not able to tolerate the same amount of load. But let's think about when we're in the clinic and we're talking with athletes that have an overuse injury. And I work a lot with cyclists, so I've kind of made a model with cyclists. What do they focus on when they say, I got this injury, and I think it's because I overpronate? And if we see here the twisted pelvis, even the Tiger Woods syndrome exists in cycling, it seems. But quite seriously, they often come in and blame it on something like this. Or they come in and they blame it on a change in their external risk factor. So it's change in their bike position or their bicycle equipment or something like this. But they very, very rarely come in and say, I've got this overuse injury and I think it's because I'm not sleeping well. Okay. But what's interesting, and I see this as a real opportunity, is that for overuse injuries, we have a really good opportunity to come in and influence this inciting event. It occurs, it's a process that occurs over time, and we, as health clinicians, physiotherapists, or coaches, or what have you, can come in and manage that in a completely different way than the way we can manage what happens in an acute situation in a game. So if we then think about what's happening in the clinic, this is more of a clinical model. So we have an athlete presenting with overuse injuries, and we have the various traditional phases of rehabilitation. To a certain extent, we want to reduce the load. That might involve even pulling them out of sport for a while. And then we want to increase the load tolerance over time and address potential risk factors, so these intrinsic and extrinsic risk factors. At some point, there is a replication of the sport-specific demands, and there's been a lot of talk about that at this conference already. And then there is a call made. Okay, this athlete is ready to return to sport. But let's now consider what happens after that point. Okay, so the athlete is being cleared to return to play, but perhaps they return back to the same old loading, okay, the same situation. They repeat the same mistakes. Then this is going to become a recurrent problem, and this can become a cycle that just repeats itself over and over. Or they can return back to a really well-structured, appropriate program and get return to play success. And I think this is something that's really important to recognize. And then think about, if most of us here are physiotherapists, what's our role? Okay, we're often here in this yellow phase, so we're doing and really guiding the athlete through these phases of rehabilitation and hopefully involved in the return to play decision making. But it's often the coach that takes over from this point and has real responsibility for this return to play success. And in this model, we see a kind of rapid transfer here, and that's what I think often happens in the clinic, unfortunately, that we have a kind of, okay, I'm finished, here you go, the athlete's ready, back to sport. But what we really need is a more gradual integration between the physiotherapist and the coach. The physio, of course, we can be involved after the return to play in continuous monitoring. So seeing if we can see when the player or the athlete is getting overloaded and maybe identify problems quickly and early so that we can do that secondary prevention, okay, minimize the consequences. But from the coach perspective, we need to involve them very, very early in the rehabilitation process. How can we do that? We've seen this model as well during this conference, and it's the model of rehabilitation, how the various sport-specific demands can be increased throughout the rehab process. And I think we need to involve coaches very early in identifying the sport-specific demands. Okay, coaches and athletes know their sports best, so they should be involved in identifying what they need to get back to. And then in certain cases, they can even prioritize the structure of the model. So we have our clinical ideas about what's important, but they also have their ideas about what's important, and that should be a discussion, and they should be involved in that process. And then progressing the athlete through the model. So I think there needs to be a transfer of responsibility from the therapist through to the coach so that the coach can guide the athlete through. And if the milestones are well set up and clearly defined, then the coach can take increasing responsibility. And so later on this afternoon, Håvard Moxnes and I, we're going to talk a couple of cases where we put this into reality, or into a real-life situation. But for now, my final take-home message in regards to the mismanagement, and that is that I think, firstly, athletes, they need to understand that it wasn't necessarily the intrinsic risk factor or the extrinsic risk factor that caused the injury, it was the load mismanagement. Okay? And that's necessary for them to understand if, when they return to play, they're going to have a well-structured and appropriate load and not just go back and repeat the same mistakes. And that we really, really need to involve coaches, okay, from the outset. I think from even the first session with an athlete, we need to bring the coaches in and involve them in the process. And that's me for now. Thank you.
I think we do have time for a few questions, actually, Ben. Thank you very much for a really interesting talk.